chronic obstructive pulmonary disease. Sorry, I almost said disorder. It's disease. COPD is characterized by both bronchitis and emphysema kind of working together, tag teaming the lungs and pretty much causing them to go to crap. So your generic or cliche COPD patient, he or she is going to have been probably pack-a-day smoker since they were 16 years old, and they never quit. Not cancer yet, but it's messed with their lungs pretty good. You're going to see shortness of breath. If they've truly called you for a flare-up of their COPD, they might be on at-home oxygen to keep their O2 sat up a little bit. But you're going to see tripod and accessory muscle usage, intercostal muscle usage, respiratory distress. And if this is allowed to progress, eventually, once those compensatory mechanisms give out, you're going to end up in respiratory failure and eventually respiratory arrest. So a bronchitis is going to be characterized by the inflammation of the bronchioles and the larger and medium-sized airway of the lungs. And it's not only going to inflame and constrict, which is a lot less air getting through, but in that tiny little space, it's also going to cause increased mucus production. So that's going to farther deter airways working. And so airway functionality is probably the best word for that. And so you might get a cough, a dry cough, depending on how thick the mucus is. It might be unproductive. You might be coughing up some phlegm. And then emphysema is going to be characterized by the alveolar walls. The walls of the alveoli are going to be destroyed. They're going to get thinner. And they're just going to be permanently jacked up. The surfactant on the inside that coats the alveoli and keeps them open, that gets pretty much most of them stop producing that. So that the alveoli is supposed to be open, and without that surfactant, it's going to be closed. So if one alveoli is closed and not very much air can get through, you're going to see a lot of pursed lip breathing, which is it's going to increase it's going to increase. It's the same thing CPAP tries to do. They're kind of trying to do it on their own. It's going to help that those alveoli stay open. So when you give a patient who has COPD or is in severe respiratory distress, when you put them on CPAP, that continuous pressure through inhalation and exhalation is going to keep those alveoli open, and that's going to make it much easier for them to breathe. With inflammation, if you hear wheezing, albuterol be indicated, and if it's severe enough, a corticosteroid like solumedrol could also be used. So the pathophysiology of the disease, like we've talked about, is so they're going to have the hypoxic drive to breathe. So you and I, we're going to be breathing based off our CO2, our carbon dioxide levels falling, and that's going to trigger us to exhale that carbon dioxide. Now, with a COPD patient, because they trap so much CO2 in their lungs constantly all the time, they might be barrel-chested as well, you might see that. But since that CO2 is trapped in there and not exhaling it, the receptors in their bloodstream or in their veins and arteries, and as well as in their lungs, they're constantly around a very high level of CO2, which desensitizes them. So their drive to breathe has nothing to do with CO2. Hypoxic meaning when their O2 levels drop, that's when they're able to breathe. So a lot of people are worried about oxygen therapy being, you're going to take away their drive to breathe, they're going to go into respiratory arrest. I believe it takes multiple hours of oxygen therapy to do that. So don't withhold oxygen or CPAP to your patients if they're not able to breathe because you're worried about taking away their drive to breathe. Likely you will not be with them long enough in order for that to happen. So you might walk in the door, you might hear wheezes when you listen to the lungs. They might have a cough, unproductive or productive. They're going to be, if they're in respiratory distress, they're going to have that, they're going to be tripoding, only talking to you in phrases. You'll see accessory muscle usage here a lot when that gets sucked down, that's a sign of respiratory distress. If you see intercostal muscles working extra hard, that's going to be a sign of respiratory distress. They've had that chronic obstructive pulmonary disease for a long time, barrel-chested, and yeah, likely a smoker, and likely they're not going to stop. So you might see their CO levels in their blood, their carbon monoxide slightly elevated. But yeah, so another thing with emphysema is it's a permanent enlarging of the distance between the alveoli and the capillaries, and that's where gas exchange takes place. So if there's a widening of that, there's going to be less gas exchange. So especially if they have a flare up, it's just going to be they constantly. I couldn't imagine constantly living with shortness of breath and pretty much just feeling like you're not going to be able to breathe. How far am I?
You're almost a 6.
Okay. I'm ending this video, and COPD, don't smoke. That's it.